We were treating AML with 7 and 3 in 1977. We're still doing the same in 2019. What is the best way forward to change it by 2029?
Right. So, progress has been slow, and I regard those 40 years of wandering in the desert with absolutely no differences in treatment. But there has been some incremental progress recently. In the past 3 years, there have been 8 new drugs approved. So I think that's exciting, but the benefits from these drugs are still modest. And that I see as a problem. So it's a matter of taking what we have and building on that. What we're really hoping for is a paradigm shift, something that is going to have that breakthrough and allow us to be curing the majority of patients. But I think until then, we have to use the tools that we have at our disposal, and that is finding novel combinations of these new drugs, how to use them best, what settings would be most beneficial, which patients are going to have the most benefit from these new treatments. And so I think that's going to be the work that will occupy our time for the next 10 years or so. And hopefully while we're doing that, there'll be new advances, new drugs, and perhaps that breakthrough drug that can target these diseases more broadly and really make a huge impact in the outcome. But so far what we've seen is incremental progress, and honestly I think for the next 10 years that's probably what we're going to be continuing with.
Okay, well, thank you. There are 3.5 million papers on cancer, 135,000 in 2017 alone. There is a staggering disconnect between great scientific insights and translation into improved therapy. So what are we doing wrong?
So I think, well, first let's ask what we're doing right. The fact of the matter is we have all of these discoveries, but my big concern is that all of this, it's a little bit like the blind men and the elephant, right? Everyone's looking at their particular pathway, their particular molecule of interest. Few people can stand back and look at the entire problem. And I think that's the missing piece of the puzzle. Analyzing all of this information that we have, thinking of this as big data and how all of these pathways interact, how we can harness this and for patients' good. The other issue is that so much of this experimental data is generated either in cultures or in mice. And as we know, these models are not perfect. And so while I think it's useful to have mouse models and they can provide a hint as to what might work in the human, there's still a huge disconnect between moving from an animal model to a human. Then again, if it doesn't work in the animal model, it's not going to work at all in the human. So I think it can provide some insight. But I think the big issue is putting all of this information together. That's what I think we need to do as moving forward to solve the problem.
Okay. Now, third question is the fact that children respond to the same treatment better than adults seems to suggest that the cancer biology is different in the two diseases, but it could also be that the host is different. Since cancer increases with age, this means that even having a good therapy may not be the answer. So, because the older individual is decrepit by definition, what is your solution for this problem?
This is a tough one because one cannot turn back the clock. And the other thing that I would say is that if it's a good therapy for a certain population and it works in them, that's great. But if it's a good therapy for that population and can't be translated into another population, then it's no longer a good therapy, right? So clearly there is a big disconnect. And you're absolutely right. When we look at pediatric ALL, those patients have the good risk chromosome and genetic abnormalities. When we look at adults with ALL, they've got all the bad risk features, right? And so children are more resilient. They can take higher doses of chemotherapy, high doses of drugs like asparaginase, which seems to be important, which adults cannot handle, right? And so you're right. There is a big difference. And so I think we need to concentrate on this older population who's really in most need. This is the major group of patients with cancer. and take a step back and look at how we can adapt our current therapies so that it's better, better tolerated in the older individual. And while we're doing that, again, think about targeting pathways, novel approaches, immunotherapeutic approaches, again, that are tolerable. Yeah, because remember, not all immunotherapeutic approaches are simple. I have so many patients who come and ask me about CAR T cells. The fact is, if you're 70 years old, you are not going to be able to tolerate CAR T cell therapy. It's quite toxic. And so that part doesn't get translated into the popular press. So again, we need to think about specific therapies for these older individuals and how we might be able to modify our current armamentarium for them while looking for more novel, non-toxic therapies in the future.
Excellent. So you have great knowledge and experience in the field. If you were given limitless resources to plan a cure for cancer, what would it be?
Right. So I think this is clearly a question of how to use all our tools, right? And so we need to think about all of our potential therapeutic modalities. We need to put the resources into basic science to look at novel small molecules, new pathways, immunotherapeutic approaches. And then we need to think about big data analysis, how to look at all of this data and combine it most effectively so that we can make rational combinations. One of the huge barriers to coming up with rational combinations is, in fact, the way drugs are currently developed. Right? So much of it is controlled by the pharmaceutical industry. They have their drug that they want to see approved, and combining this with a potentially useful drug from another pharmaceutical company, not so easy. No one has a vested interest in it. So it would be a fantastic project to get all of these potentially useful new drugs into a general basket so that and I think here's where academic medicine can really come into play. We can combine those drugs rationally and with an agnostic eye towards who will share in the profits at the end. Again, it's major resources on all fronts: basic science, clinical research design, novel drug combinations.
The last question is a little philosophical. Offering patients with its advanced stage non-curable cancer palliative but toxic treatments is a service or disservice in the current therapeutic landscape?
Yes, you're right. It's a philosophical question. And in fact, that's usually how I frame the discussion when I'm talking about this with patients. I tell them it's not a medical decision. It's a philosophy of life decision. So, one of the tenets that I always go by is we don't want to make the treatment worse than the disease. I think that's always something that's in the forefront of my mind as I'm recommending therapies to patients. And treating cancer is really going on a journey. When someone comes to me with newly diagnosed leukemia, we're going to do our very best to try to cure them. And of course, if we do, it's a win-win. Everybody can celebrate. But if the disease comes back or they're refractory and things are not working out, then we move into that palliative care modality. And eventually, when even palliative treatments don't work any longer, then we're talking about supportive care only and end-of-life care. And so moving from stage to stage, getting the patient on board with this, taking their family on this journey, this is really the biggest challenge that I face on a day-to-day basis. After a while, picking the medicines are relatively simple, but that individual patient's journey is never simple. And so I frame it just as you did. We have a therapy. Here are the side effects. Here's what to expect. Here's realistically what we can expect from this drug. It may make you live a few months longer, but much of that time could be spent in the hospital. And so we begin to introduce the notion of quality of life versus quantity of life. And I have some patients that would say, look, if I can live a month, if I can live a day longer, I will take this new therapy. That's how precious life is to that individual. Others would say, if I have to endure these sorts of side effects right, this is not worth it to me, this is not how I want to live my life, then that's an equally valid viewpoint. And I try not to impose my own ideas on patients, but really view this discussion as just that, a discussion about what the patient wants, how they want to live their lives. And I see my role as being an educator. And hopefully we can arrive at the right decision for that particular patient and complete that journey.
Just before I end, thank you so much. This was a very moving answer. But many patients ask me the question. I wonder how you respond to it when they ask you, Doc, if you were in this position, what would you do?
So, I do get that question. And I do frame it many times as what I would do or what I would do if this were a relative. But I will give them an answer, but I'll say that's the answer for me. That's not the answer that's necessarily the right answer for you. And so I think it's always important to remember that we're not making a medical decision here. There's no right answer. And so it's got to be what's right for that individual. And so no matter what we think, we shouldn't impose our viewpoints and our feelings on our patients, but be there to support them, whatever that decision is.
Thank you so much. Those were great answers. I'm very grateful. Thanks, everyone.
Thank you.
Thank you. Bye.